Hello everyone, welcome to another NP Academy lecture. Today we will talk about how to diagnose and treat poison ivy rash. So we will talk about poison ivy rash. This is the perfect timing to discuss this topic as poison ivy rash tend to peak during the summer months. So let's talk about it. We will talk about what cause it, what are the signs and symptoms that patient will present to you, how you will diagnose them, diagnosis, how you will treat them, and we'll talk about the prevention at the end. So let's talk about the cause first. Here in the United States, there are 3 different plants that can cause the rash that we commonly call poison ivy rash, and they are your poison ivy itself, poison oak, and poison sumac. All these 3 plants belong to the same family and their biological name is Toxicodendron. This is a Greek word. The toxico means toxic and dendron means plant. Basically it's a toxic plant. These plants tend to have a unique structure. They tend to have this 3 leaves that's coming out of one stem. And these plants produce this oil, and this name of this oil is called urushiol. It is this urushiol that acts as an allergen and causes the rash. So when you get exposed to the poison ivy while you are hiking or working in the yard, the urushiol, say for example this is your skin. It's your skin. So when you get exposed, this urushiol come onto your skin surface, and within an hour or so the urushiol will diffuse through the skin and get inside the epidermis, and then in the epidermis you have this special kind of cell, and we call it antigen presenting cell, APC. These antigen presenting cells take up this urushiol. Let's keep this green here. They take up this urushiol and then they process it into this small little pieces, and this process is called antigen processing, and then this part of this antigen get expressed on to the surface of antigen presenting cell like this, and this process is called antigen presentation. Then you have another cell in the body that's called your T cell. This T cell recognize this, and in response to this allergen, this T cell get activated. And when this T cell get activated, this produces a lot of different cytokines. And some of them are interleukins, interferon, and it is these cytokines that actually cause the tissue damage and cause the rash along with intense itching, redness, swelling, and pain. And these are the cardinal sign of poison ivy rash. So when we talk about the sign and symptoms of poison ivy, these are the sign and symptoms that patient will present to you, and this is caused by these cytokines, interferon and interleukins. So let's look at this. This reaction is basically allergic reaction, and allergen is here urushiol, and the affected cells are your T cell and your cytokines, and these reactions tend to be delayed reaction, and the delayed because of the involvement of T cell and cytokines. So this reaction also called delayed type hypersensitivity reaction. So DTH is delayed type hypersensitivity reaction. So generally it takes some time for these rash or these symptoms to develop, and usually it takes somewhere between 4 hours to 96 hours after the exposure when these symptoms develop. Sometimes it can take up to 21 days for these rashes to develop, mainly because this is a delayed reaction. But most commonly though, patients tend to have the symptoms between 12 to 48 hours after the exposure, once they get exposed. That's the most common, 12 to 48 hours. However, it can be as quick as 4 hours and as late as 21 days. So this is the sign and symptoms. Okay, how you will diagnose them? When it comes to diagnosis, there are two parts of diagnosis. One is your history, and history you will ask about any outdoor activities in last 2 to 3 weeks, mainly because of the delayed reaction. Sometimes it can take 21 days for symptoms to develop. So last 2 to 3 weeks. Other one will be to any previous history of poison ivy rash and previous history. Sometimes patient can get this kind of rash or the exposure from the pet. So say for example, if you have a dog, so pet exposure, and if your dog is playing around outside in the yard, they can expose to the those poison ivy, and then the dog come and play with you, and then you can get through that. So it's very common to get through the pet. So that's the history. On the physical exam, you will notice that they will have a usually linear or the streaky pattern of the rash in the area where you got exposed, and most commonly these are the extremities, either upper extremities or lower extremities, and these rash could be most commonly appear to be like a plaque. However, sometimes it can also be vesicle, or sometimes it can be bulla, like a blister. Just so you know, the fluid that is inside the bulla or vesicle, this fluid does not have uroshiol, so this will not cause the rash. So based on this physical exam and history, you will diagnose the poison ivy rash and poison ivy dermatitis. Okay, well, how about treatment? How you will treat them? So treatment. For the treatment, you need to understand two most important things. The first thing is that you will have to treat them for 2 to 3 weeks. And the reason is that as I was saying, it's a delayed reaction. Symptom may develop up to it may take some time, 21 days to develop. So you will have to treat them for 2 to 3 weeks. Other problem is that if you treat them for the short time, for a week or so, these patients tend to develop something called a rebound dermatitis. So if you treat them for 2 to 3 weeks, chances of having rebound dermatitis are very slim. So that's one thing. Another important thing is that you will treat them with steroids. Okay. When it comes to steroid, the question is whether you will use topical or oral. Turn out topical is not very effective in the treatment of poison ivy rash. Very rarely, as a matter of fact, I have never prescribed topical for poison ivy rash. However, if you have to use the topical, you need to make sure that the rash is very localized in a one body part. It's not on the face and not on the groin region, and you want to start the treatment early. Once the rash is established, then these topical medicine tend to be not very effective. And to use the topical, you want to use the high potency steroid. So the hydrocortisone is not going to make any difference. However, by the time patients come to us, they usually have more than one body part involved. Most of the time they have this rash on both upper and lower extremities, sometime on the face and on the body, chest. So it's very common to prescribe the oral steroids, and usually you will give them taper regimen over the course of 2 to 3 weeks. For 2 to 3 weeks. And once you establish this, then there are a lot of leeways to develop your regimen plan. Any taper regimen will work as long as you are covering for 2 to 3 weeks. So I will share with you here my style, what I do. I usually start them out on the IM steroid. I give them first dose of 1 dose of either combination of solumedrol 40 milligram plus depomedrol. This is the you mix them both and give them in one shot IM 40 milligram too. These solumedrol and depomedrol tend to be very strong steroid. If you compare the strength using the hydrocortisone as a standard, if the hydrocortisone is 1, they tend to be roughly 5 times more stronger than hydrocortisone. So very strong. Solumedrol tend to have a quicker onset. So within an hour and 2, you will start to notice the difference. So it's a quick relief. Depomedrol, on the other hand, it's a depot shot. So it goes into the muscle and it slowly releases in the body over the time. So with the depomedrol, you can get coverage all the way up to 3 to 4 weeks. But most commonly though, you have a 2-week coverage for sure. So give them this one time only. It's really good. Or sometime, if not this, then or you give them decadron or dexamethasone. Usually we give them for the healthy individual 10 milligram one time. Now compared to hydrocortisone, this decadron is really very strong. It's up to 30 times more strong compared to hydrocortisone. So it's really strong. And decadron tend to be your long acting steroid. So usually it can last in your body, once you give them 10 milligram one dose, usually it will last somewhere between 5 to 7 days. So you really have a good coverage. So either combination will work, either decadron or the combination of solumedrol or depomedrol. Or if you don't give them IM and just give them P or taper, that will work too. But this is my style. And then after that, I give them prednisone. This is just like solumedrol compared to hydrocortisone, usually like 5 times stronger. And we gave them oral, so PO. Patient take once a day, daily, usually in the morning, the AM. And I gave them 40 milligram for 7 days, then 30 milligram for 3 days, then 20 milligram for 2 days, then 10 milligram for 2 days, and then 5 milligram for 1 day. And this 2-week regimen works really great. First of all, it has a really good compliance. Patients tend to take it. Other thing is they have done a lot of research and they found that 2-week regimen does not cause much rebound dermatitis. So it's really safe and works great. However, if you want to give them for 3-week regimen, that will work too. And 3-week regimen may look like this. You can give them 40 milligram for week 1, then 30 milligram for week 2, and then in the 3rd week you start with the 20 milligram for 3 days, 10 milligram for 2 days, and then 5 milligram for 2 days. Either or will work. However, I usually give them 2-week regimen. Okay, so this is the biggest thing in the treatment. How about antihistamine? Do we prescribe them antihistamine? If so, will this help antihistamine? Well, if you look at the pathophysiology, there are no histamine involved in the development of rash or anything. It's all cytokine based and the T cell based. So there are no histamine involved in the development of rash or itching, So giving them antihistamine will not make any difference. However, we do prescribe them antihistamine, and the reason is this, that you have a 2 generation of antihistamine. The first generation is your Benadryl. if you remember correctly, one of the side effects of Benadryl is your sedation, because it crosses the blood-brain barrier and make you sleepy. And because of the sedative properties, we use Benadryl in the treatment of poison ivy rash. We ask them to take patient 50 milligram at bedtime. So basically it put you to sleep. It will not do anything to itching, but just to sleep, to help you with that. The second generation Benadryl, on the other hand, like your Zyrtec, cetirizine for example, the second generation does not have a sedative role. So prescribing them the second generation antihistamine in the poison ivy rash will not make any difference because it's not sedative at all. So do not prescribe them the second generation Benadryl. That's it. So this is all about treatment. Okay, well, lastly, let's talk about prevention. Well, the most important thing is that if you get exposed, then wash your arm and hand and tools and your pet, and most importantly, wash under the nail bed. That's more important. When it comes to gloves, they found that gloves that are made up of vinyl tend to be more effective compared to any other gloves, compared to like latex gloves or cloth gloves. So get the vinyl gloves. The barrier cream, there are a lot of barrier cream out there over the counter, and we really don't know how effective are those cream. However, they did clinical trial and they found this one barrier cream that's also over the counter, and this name is bentoquatam 5%. This has proven to be effective by clinical trial. So use this one. The way this works is that you will use 15 minutes prior to going to do outdoor work, and after that you can use Q 4 hour, every 4 hour as needed. What this bentoquatam do is that this actually binds to urosol. This bind to urosol. So urosol does not penetrate to your skin because it's getting activated. So this is the way you get prevention. This is all about poison ivy rash. Hope you will find it useful.